commercial
Yes.
first, but there's not very many people here anymore.
Maybe we can wait a little bit. Should we wait a little bit until more people show up? All right, we'll get started. Good afternoon, everyone. Thank you for attending. Today we'll be talking about multimodality imaging and cardiovascular prevention. I have no relevant disclosures, and I'm going to start by kind of thinking about cardiology and making some parallels to other specialties that have made a dent in kind of improving patient care. So in cardiology, we are lumpers. We try to lump all diseases together, and even when diseases can be looked at differently, we try to put them together as one bucket. So for example, when we think about carotid disease, coronary disease, peripheral arterial disease, renal artery stenosis, we start to lump them all together through atherosclerotic cardiovascular disease. And we sometimes are even lazy. We don't even call them atherosclerotic cardiovascular disease. We start calling them ASCVD. So in cardiology, we're very, very we shorten things, but also make things very, very abstract. Let's contrast this with oncology. Oncologists are splitters. They don't even think about colon cancer as one entity. You have a colon cancer with this gene mutation, you have colon cancer that's at this location, you have a colon cancer that has this phenotype, and so on and so forth. And that kind of made a huge dent in oncology because they started to think about disease-specific phenotyping that led to discoveries and therapies and so on and so forth. One could argue that it's the other way around, that the availability of therapies required the phenotyping, but oncologists have always been thinking about disease phenotyping from the get-go because they have access to tissue and biopsies and things like that. The other thing that we have been doing, in my opinion, wrong in cardiology is that we are also very binary, right? We think about positive versus negative ischemic tests, right? Positive versus negative. You either have coronary disease and you don't have coronary disease. In reality, this is not true, and risk is actually more of a continuum. Now, in the recent, probably decade or so, we started to think about stages of disease. So this is one example of staging of disease, stage A, B, C, D. You can think about it in heart failure. You can think about it in atherosclerosis. You can think about it in myocardial infarction and so on and so forth. But I would argue that the staging also comes at agnostic to the outcomes, which comes before the outcomes. And one classic example of this is CKM, cardiovascular kidney metabolic disease. The staging came without looking at the outcomes, and now after we made the staging, now we're starting to look at the outcomes, and we're realizing that the staging mechanism is really not fitting with the outcome staging as well, right? And that's a problem. So I would argue that there's a lot of patients who are in stage A, they actually have higher or worse risk than stage B or C, and vice versa. There are patients in stage C that fit under the classic stage C, but they actually have an outcome that it looks like it's stage A. So what we're arguing for is really a continual risk that is also dynamic, that patients can go from one risk category to another, but also not thinking about these arbitrary cutoffs at the edge where there is really no difference between high risk stage A versus low risk stage B. And we have ways to actually communicate that risk. Now, the other thing that I think we get wrong in cardiology is really reliance. We love these risk scores, right? Prevent in Framingham, and the entire field has been built on risk scores. And I think these risk scores can be helpful at a population stage, at a population level, but sometimes they can be first misleading, they can be misused. But also there is a big problem. This is, you see a patient today, prior to the visit, the MA gets blood pressure, gets GFR, all these things. You plug in the numbers, great. At the end of the visit, you remeasure blood pressure, you remeasure their weight, and it's very different. And that's variability, natural variability in our measurements. And you get a very different risk score, right? So even within the same visit, 10 minutes apart, sometimes you can get very different risk scores because it relies on a lot of these measurements that are not reproducible. Systolic blood pressure is not reproducible. eGFR is not reproducible. And BMI is not reproducible. So you have this kind of impact on patient outcomes without actually having to rely on reproducible variables. It's also, when we train these models or kind of derive these models, they're derived on a very classic population, cohorts, MESA, and others that are not reflective of the real world. There was just a paper last week from Kaiser that looked into African American young individuals and applied the PREVENT score and showed that it severely underestimates the risk, right? So we're starting to see all these issues with these risk scores that can highlight their limitation in clinical practice. But in my opinion, I think the biggest hurdle of these risk scores is really nobody uses them. If you look broadly, right, even at top-notch academic centers, right, people don't use them frequently. And let alone in patient, busy clinical practices in the community where some variables are not available. In some studies, it's only like 50% of the patients have available data to actually even calculate, and let alone actually people doing that. So there's a lot of issues with risk scoring. So why do we need a reset for prevention? I think there is expanding pathomechanisms, but also there is expanding and emerging therapies. Preventive cardiology has been boring in the past 20 years. About 10 years ago, we used to rely on these two medications, literally, that's what we used to give. But now, even in the past year or so, there is a lot of emerging therapies, and now we are kind of bombarded by different therapies, and now this requires us to prioritize and understand which patient benefits from what. So we need to understand to which patient do we give ezetimibe versus PCSK9 inhibitors versus inclisiran, which patient do we need to give Xarelto versus dual antiplatelet therapy, and so on and so forth. And this is just emerging. This is more and more. You can see even in the past year in New England Journal of Medicine, there is a lot of interest in lipoprotein A, which the outcome trial will be presented in AHA later this year. There's vascular inflammation data. There is now ApoC3 inhibitors that focus on hypertriglyceridemia. There is CRISPR-Cas9 on gene editing. There is fish oil, re-emergence of fish oil focus, and oral kind of formulations of PCSK9 inhibitors and GLP-1 and kind of triple agonists and so on and so forth. So there's a lot of issues that are emerging that requires us to start to think about the patient slightly differently. Now, if you look at the studies generally, when you look at the pyramid of risk factors, whether it's primordial, primary, or secondary prevention, the closer you get to the phenotyping that's closest to the outcome, then you get a better discrimination. So if you are doing an IVIS or a cath is a good predictor of an outcome in the next 30 days. But as you get away from it, so genetics, environment, behavioral risk scores can only give you like a C index of 0.5 to 0.6 discrimination. As you get closer, like risk factors, which is prevent scores and ASCVD risk score and Framingham, it gives you a slightly better C index because we're focusing on phenotypic risk factors, diabetes, high blood pressure, and so on and so forth. And as you get closer to the event, as you get closer to the factor or the biomarker that is related to the event, in this setting myocardial infarction, for example, then you get a better C index. And that could include calcium scores and coronary plaque. So this gives you kind of the bottom two-thirds gives you the risk exposure. This gives you the disease expression. And then the interaction between them gives us who is susceptible, who is resilient to the conditions. When we think about precision phenotyping framework, we're thinking about different things. So as you get closer to an MI or coronary disease event, ideally an MI here, you see a plaque erosion and diastolic systolic dysfunction, ECG abnormalities, clinical symptoms, and alveolar modeling. But before that, we have a lot of biomarkers that we can identify on patients, whether it's endothelial dysfunction, monocyte recruitment, apoptosis and angiogenesis, and some of these markers that are reflective of pathomechanisms for coronary disease can be identified through imaging or surrogates. We also think about kind of the spectrum of coronary disease, and for the most of this presentation, I'll be focusing on coronary disease and atherosclerosis, but think about also outside of that, this could be applied for heart failure and other things. Generally, we're kind of starting to think about different staging. So there is some emerging data on some radio tracers that can identify the biology of inflammation, for example, of FDG PET, but also there is sodium fluoride that can identify calcification and calciogenesis. We have perivascular adipose tissue that can identify inflammation. We are looking into quantitative burden assessment, and then remodeling as assessed by high plaque risk features, and then to all the way down to kind of computational fluid dynamics to estimate ischemia and FFR. And this is all based on a singular CT and or PET that can identify this spectrum of disease as atherosclerosis builds over time. Now, the dogma in cardiovascular medicine in general is that we've relied a lot on ischemia testing, right? We even diagnose patients who have coronary disease based on ischemia testing. But remember that 2/3 of myocardial infarction, they have non-obstructive disease if you were to test them a month or two before the event. And only at the latest, kind of in the 3 months preceding the MI, that's when the clot is forming, that's causing ischemia, causing blood flow limitation, that you can see that there is up to 2/3 of the patients about 1 week prior to MI, they would have obstructive disease. So just relying on non-obstructive or obstructive disease based on ischemia testing, this is not even thinking about the limitation of the ischemia testing itself. This is if you have a cath and you do a cath 3, 4, 6, 10 months prior to an MI, and you get a non-obstructive disease, that does not mean you're still missing 2/3 of the patients that will end up with an MI. So I will spend a few slides on calcium scoring. In 1990, Dr. Agustin did an electron beam CT study on about 90 patients and showed that you can identify these calcifications, and these calcifications have then were validated with autopsy studies in about 20 patients or so, and showed that it correlates the amount of calcification on this electron beam CT can correlate significantly with the plaque burden on autopsy studies. So if we review the biology of coronary calcification, this is you get some intimal thickening in the beginning, and that leads to either thick cap, which can change into a thin cap of endothelial cells that can then rupture, or it can cause nodular calcification. If it doesn't progress fast, it could actually heal, and it can result in nodular calcification, which is a stable disease. This thick cap can transition into either a thin cap or ulcerated plaque, then leads to a stable plaque by itself. And then you have a fibrocalcific plaque, which is a combination of these two. And then combination of these thin cap and with the fibroatheroma can result in a ruptured plaque that leads to a myocardial infarction. What happens in coronary calcification? Why is coronary calcification an important thing? It's actually an active event. What is happening is you get this deposition of intimal thickening, which is really lipid lipoproteins, and then you get monocytes that come and try to really attack some of these byproducts and inflammatory byproducts and then call for more monocytes. But at some point, you start calling these green cells, which are osteoclasts or osteoblast looking like cells that start kind of eating up the excess of this byproduct and deposit small amount of calcifications, which over time can lead to either microcalcification, which is a really it's a plaque that's prone for rupturing, or you get a macrocalcification, a nodular calcification, which we see on CT. And this is a process that's active. We can actually pick it up. This is a study of sodium fluoride. Sodium fluoride is a radiotracer that looks at this calcification deposition, active process of calcification deposition. It's widely used in prostate cancer, but this is a study that looks at these calcifications, and looks like these calcifications are stable, but these calcifications look like they're active and they're being deposited. This is in the coronary, this is in the carotids, and so on and so forth. Now, how do we even measure Agustin score or calcium score? We do these thick slices, 2.5 to 3 millimeter CT, and what we do is we identify the pixels that are intense, 130 Hounsfield units and higher, and then we count them, and then we basically multiply them by the maximum intensity. So it's a little complex because it's not very intuitive, like why are we multiplying them by intensity and so on and so forth, but just this is the methodology that was described. Is you take the area of that plaque or that number of pixels exceeding 130, and then you multiply them by an adjustment factor, and that adjustment factor is the peak of the Hounsfield unit. So if you have few voxels or few pixels that are more than 400, then you give a factor of correction of 4. If they're 300 and 399, peak value is 3, and then 2 to 299 is 2, and so on and so forth. And then you start adding up all these slices together, and you come up with a total Agustin score. So you can imagine that we can sometimes have varying degrees of calcifications. You either have a lot that is not dense, a lot of calcium that's not dense, versus a little calcium that's highly dense, and that leads to equivalent Agustin score. But we know from biology and from studies that these two patients will have very different trajectory. Now we have a lot of studies now on this calcium score and the outcomes. This is one of the earliest studies in 2008 from Mesa that looked into long-term outcomes, whether you define it as incidence of major coronary events or incidence of coronary events plus revascularization. And you can see that there is a nice graded risk between calcium score and outcomes. Traditionally, people have defined these categories, again, somewhat arbitrarily, and again, this goes back to the staging framework that we use in cardiology, but basically calcium score of 0, 1 to 99, 100 and 100 and 200, between 100 and 300 and more than 300, and then you can see that patients who have a calcium score of 0, they get really very, very low risk of of events. Now, we and others have shown that the amount of calcium score can classify the risk based on ASCVD risk scores. So we're showing you here that even when you have a very low ASCVD risk, this is pooled cohort equation, less than 5, you still have about 8% of the patients have more than 100, calcium score more than 100. And when you have a very high calcium score, when you have a very high pooled cohort equation risk estimate more than 7.5, still about 1 in 4 patients will have a calcium score of 0. And in these situations, calcium score usually trumps the pooled cohort equation and ASCVD risk. And the same thing with the PREVENT score. Even when you have very high PREVENT score, 1 in 6 patients will have a calcium score of 0. Several studies have shown that calcium score is probably the best non-invasive test beyond CTA that can identify risk of MACE events. And when you look into comparison with Framingham risk scores and other scores, this curve here stands out as the calcium score. And then when you start adding even polygenic risk scores, only calcium score adds value. Polygenic risk score does not add value beyond the ASCVD risk score. So there is now data to suggest that calcium score is very reasonable and very important as a determinant of outcome. And this goes back to this pyramid of evidence that I showed you, that C indices that we see with calcium score are approximately 0.7 to 0.6. When you look into polygenic risk score or ASCVD risk scores and things like that, you get generally 0.6 and below. What do we do with this information? Now, we don't have randomized trials to say, okay, if you have a high calcium score, what do you do with this information and kind of things, but we derive most of our information from retrospective, well-characterized retrospective and prospective studies. This is a landmark study that looked retrospectively at patients who underwent calcium score and then looked at patients who received statin versus no statin and looked at the outcomes. When you have a calcium score of 0, really statin does not make a big difference. And as calcium score goes up, you start seeing a big difference between those who receive statin, lowering risk with the patients who receive statin, and the hazard ratios go, between 0.3 and 0.56 for those who have more than 100. So that tells us that when you start having, this is the main evidence to suggest that if you have a calcium score below 100, statin may not really provide a lot of benefit, at least in using this retrospective study. But when you look into calcium score more than 100, that's where the benefit comes in. Of course, there are some limitations with this study, given its retrospective nature. Same thing for aspirin. Calcium score 100 and above seems to suggest that there is a benefit, although we don't actually know that for sure. There is some ongoing studies that are tagging along some of the big randomized trials called adaptable trial that shows us the same, that will hopefully show us a little bit more information about aspirin use in patients who have elevated calcium score. Now, people have done a lot of these studies where what the risk of calcium score is and how it relates to MACE events. What if we start looking at pre-existing therapies, whether it's semaglutide or PCSK9 inhibitors, and say the hazard ratio from that trial applies the same way to all my patients, but all that is different is the absolute risk. So my absolute risk reduction will be higher in patients who have a high risk score, so meaning that the number needed to treat will be smaller. So you can see in this study, looked at a couple of cohorts and looked at the incidence of MACE by calcium score, and as expected, incidence of MACE is higher. But then what they did is they did that conversion and estimated the number needed to treat with semaglutide if you have a high calcium score versus low calcium score. And you can see here to prevent one MACE or heart failure event, if you have a calcium score of 0, you need to treat 400 patients over 3.5 years or 3.3 years. But if you have a high calcium score, you only need to treat about 50 patients. So the number needed to treat, as expected, can go down because the absolute risk is going up. Now, when we talk about calcium score, we've always thought about calcium score as a primary prevention, but there's a graded risk between calcium score and events. And when do we start calling calcium score a coronary disease? Every time we go to conferences, I start asking this simple question: what is coronary disease? Because now we're having a lot of different tests that does not fall into this older category of positive and negative stress tests. We have everything in between. We have quantitative metrics. So what is coronary disease right now? So this is one of the studies that looked into what if we divide the patients, the primary prevention, quote unquote, cohorts, and divide them into calcium score and compare the calcium score categories, the outcome of the calcium score categories with patients who have pre-existing ASCVD, atherosclerotic cardiovascular disease, with respect to outcomes. And here you can see the yellow here is prior ASCVD, and patients who have a calcium score of more than 300 have almost identical outcomes compared with these patients. So this study suggests that when you have a patient who has a calcium score 300 and above, then you should really think about their risk equivalent to how you think about a patient with established coronary disease. So people are, we go back to the staging system. We love staging in cardiology. So people started to think about, okay, how do we stage this? And again, these staging, different people propose different staging. We like the staging that uses an absolute value of calcium score, but in this case, the staging uses a combination of calcium score and the kind of the percentile. So if you have no calcification, no calcium score of 0, then you just use your basically your guidelines to, assuming that you don't have any calcification, you use your guidelines. So you say, all right, adopt good lifestyle, exercise, diet, life essential 8, things like that, and only prescribe statin if the LDL is more than 190. They also suggest that if you have a high-risk population, for example, smokers, South Asians, patients who have elevated lipoprotein A, you may consider pushing them towards statin a little bit as well to reduce their risk factor. And then you want to repeat their calcium score in a due period. That period is not well determined, but based on this recommendation is 3 years for patients who have diabetes, and then 5 to 7 years for patients who have low 10-year ASCVD risk. To simplify the story, I think if you have a calcium score of 0, you could recommend a repeat calcium score in 5 years or so, especially if they have a high-risk situation, high-risk profile. And the idea is because it all depends on where do you change your therapy. If your practice is to change therapy and change statin indication at a calcium score of 100, it's very unlikely that you go from 0 to 100 when you are within 1 or 2 years of repeat calcium score testing. And as risk goes up, you start to intensify therapies. So you go to statin, obviously. Some people recommend low-dose aspirin, especially when the calcium score is more than 300. And then the more than 1,000, you start treating them, in my opinion. I tried to.
Yeah.
Yes, sir.
Where does age plays a role? So 65 has a score of 0. At 75 becomes 70, 80. But now it's 75 or 78. Age has to play a role somewhere in that equation.
Right. So you can think about.
Versus a 50-year-old that goes from 0 to 75,
Right.
By
Right.
age 55.
Right.
They're different animals.
Correct. And you can think of it, so the question is about age and how do we think about age with repeat testing, as I understand it. And I think you can think about age in 2 different ways. If a patient is 75 and has a calcium score of 0, very unlikely that they will go to a calcium score of more than 100. That they just basically declared their phenotype, right? They've lived 75 years of their life with a calcium score of 0. But also, as you get older, there is a higher acceleration of calcifications generally. I don't know actually whether this has been modeled specifically, whether people have estimated this based on specific age. There are a couple of risk equations that people have estimated from MESA that looks, you plug in the number, it tells you what is your warranty period or how often do you need to repeat. And we can test that and see what age has to do. But these are based on small studies because we don't have too many cohorts that has done, repeat testing in this scenario. But the great question.
Sadiq?
Yes.
Is that why the guidelines have the percentiles? You can look at
Yeah, the percentiles have, with age, you obviously have a higher risk, right? As you get older, you have a higher risk of calcifications. Now, is this a broad phenomenon? Is this something that we should consider as normal aging, right, with the increasing calcium? Because approximately 10 to 15% of patients 75 and older in the ERIC study have no calcifications, zero, calcium score of zero. So do we consider those 15% to be healthy agers, the outliers, or do we consider them to be that's what we should accomplish, right? But yes, the guidelines do recommend that we look at the percentiles because a high calcium, for example, even calcium score of 1 at a young age may signal a different risk compared with a calcium score of 1 in a 75 and older patient. I think this is yet to be determined. I think this is overly simplistic in my opinion because just percentiles by themselves may not give us the full story. I think vascular age might be an interesting thing to think about it. Vascular age is a more advanced way of thinking about it where you integrate risk factors with age, with calcium score, and it gives you a true vascular age. And if you compare the vascular age with the chronologic age and say that you're a more accelerated person, then maybe we should pay more attention to your prevention. But I think this, we try to balance simplicity because simplicity has wider adoption, and that's why I like just the cutoffs and do the mental math in my mind for percentiles. Now, can we think about calcium scoring as an intervention itself, right? So we've always thought about calcium scoring as a means to identify patients, but what if I kind of do calcium scoring and that's the only intervention I'm doing to patients, right? And see what happens downstream. Look at primary cares, what they're doing, look at cardiologists. And it turns out that when you do this, and this is what we did in Cleveland where we did it for free, calcium score broadly, what happens is you get a graded risk dose-response relationship with statin initiation. So this is in blue, you get a calcium score of 0. You get, and red, green is a little bit higher calcium score, and so on and so forth. As your calcium score goes up, people are more likely to get prescribed statin. So about 3 years later, and this is without telling them anything. This is just doing the calcium score as the only intervention. And then you also see that as time goes by, there is a change in LDL. So we see approximately in those who have a high calcium score more than 400, again, using only calcium score as an intervention, we see a significant reduction in LDL cholesterol, which is not a surprise because we're seeing a graded initiation of statin. Now, there is actually a randomized trial. The data that I showed you was a prospective cohort study, but this is a randomized trial that just got published recently in JAMA, where they took people, about 400 people, 350 people, and then they randomized them to either give them calcium score and inform them of the results and kind of guide them into prevention versus usual care. And what they did is they did a CTA at baseline and CTA at follow-up, and then they looked at total plaque volume. So they did not give them the results of the plaque at baseline, they only gave them the calcium score. And they're using the CTA as a measure of the study intervention. And what they showed is that there is actually a significant reduction in plaque burden in those who received calcium score versus those who did not receive calcium score. In Denmark, they did a very large study called DAN-CANVAS. Now there are 2 trials in DAN-CANVAS. DAN-CANVAS 1 and DAN-CANVAS 2. What they did is they said, all right, let's take men specifically, 65 and to 74 years of age, and let's just randomize them to either invite them to doing screening, which includes calcium score, ABIs, and blood sample for diabetes and lipids, versus no usual care. And let's follow them up. And the primary outcome was death from any cause. And it turns out that there's really no, the invited group had a non-statistically significant reduction in mortality, but it did not meet the primary endpoint. Of note in this study, which is about 46,000 patients or participants, not many people underwent. Even if you're inviting them, not everybody underwent the study. So there is some contamination between the groups. Now, there was a secondary study that followed this up called DanCavis-2, which was just recently published a couple of months ago, maybe a month ago, that looked at slightly younger age groups. So this was 65 and 74. They took a decade earlier and they said, okay, let's look at that patient population and do a similar trial. And that trial by itself, when you start combining them with DanCavis-1 and DanCavis-2, Dr. Nasser and Safi Khan, who was a fellow here, did this meta-analysis of the two studies. And what you see is that per 10,000 patients screened, you prevented 60 deaths, which is a very strong signal. You prevented 55 events of MACE, but you also increased bleeding, presumably due to increased use of aspirin by 65. So this kind of provides us with one of the first large evidence, national level evidence of the efficacy of such an intervention that's broad. It still needs to be refined into what's the right patient population, what is the right intervention, and so on and so forth, but that's important. Now, as I mentioned earlier, Agatston score can actually give you one number per patient, but these two patients have the same calcium score. So it turns out that if you have one dense plaque, which you can think of it as an older plaque has built over the years and has high intensity, this patient has a calcium score of 200, and this patient has a diffuse, younger plaques, more diffuse plaques across multiple vessels, and this patient also has an Agatston score of 200. And these two patients actually have very, very different outcomes, because it turns out that diffusibility or diffusiveness of the calcifications identifies patients who are at higher risk. And the evidence suggests that if you have CAC area that goes beyond Agatston score, the more CAC area, the more the risk. The less CAC density, which I just mentioned to you, can actually be protective. So higher CAC density is higher risk. You have heterogeneity across the number of vessels and so on and so forth. So there is more data beyond just the total Agatston score that can further risk stratify the patients. And we don't use this very frequently, but that's something that we should be probably paying attention to and incorporate into our reports as time goes by. We actually have done work on what if we take all the features of the calcifications, not just one singular feature at a time, but let's take into account the location, the density, the diffusivity, the kind of the spikiness of it, and so on and so forth. And we've shown that this actually can predict risk of MACE much better compared with an Agatston score. So this is kind of Agatston score 2.0, version 2.0, that hopefully will be at some point the actual reporting that we get and move beyond just an Agatston score and just tell you what the risk of the patient of having a risk in 10 years, for example, 5%, 6%, 7%, and so on and so forth. Just one word on CAC progression. Multiple studies have shown, as can be intuitively identified, the patients who progress calcification, they are at higher risk for MACE events. And this is just one of the studies from MESA that looked at those who had no change in their calcium score. They had lower risk compared with those who have progressed calcium score. And this is in patients who have calcium at baseline, and patients who have zero calcium, the divergence of the curve is even higher if those remain at calcium score of 0 over time versus those who progress their risk. As you probably have read or heard, that there is now models that can take a non-gated CTs, chest CTs, done for lung cancer screening primarily, or for lung cancer, for lung disease, and basically identifies the calcifications. And it turns out that this calcium from non-gated CT correlates very well. People have done this manually, but now there is automated tools that can take it. And this is one of the studies that looked into, I think it's from Stanford, that looked into this deep learning classification of calcium scores from the chest CT and showed that it's associated with the higher the calcium, it's the more risk of death, myocardial infarction, stroke, revascularization, so on and so forth. And this is hopefully we'll be getting this service in Houston soon, Houston Methodist soon. Now, just remember, this is something that's interesting, that always interested me, that not all that glitters is actually calcium score. And we've been taught that, okay, when you look at this bright stuff, this is always calcium, and this is always atherosclerosis. But with the advent of dual energy CTs, now we can classify the material. There's something called material decomposition. The radiologists use it a lot for kidney stones, to identify what type of kidney stone do you have. And in this study, this group of authors, what they did is they took patients who have gout. As you know, gout is a uric acid deposition. And they did material composition on cardiac calcifications, coronary calcifications, or what is perceived as coronary calcifications. And it turns out significant portion of them in green, significant portion of them are actually uric acid deposits. What does that mean? We don't know. How do we attack it? We don't know. How do we treat it? I don't know. But that speaks to the phenotyping that maybe in these patients who have some uric acid deposition, specifically a lot of it in the coronary arteries, we may need to think about uric acid medications and lowering medications, febuxostat or allopurinol or others. Now, the limitations, as you all know, with the calcium score, we're only identifying calcified plaque, but there's a huge amount of non-calcified plaque that we may not be identifying. So what is the prevalence of that? This is Dr. Nasser's study, Miami Heart, that looked into population-based calcium score and CTA. They invited people from the community. A lot of them are Hispanics, and they just did CTA and calcium scores. And in those who have a calcium score of 0, we see approximately 1 in 6 patients will have some coronary plaque. But it turns out that these plaques are primarily not obstructive. So less than 1% of these of the patients who had a calcium score of 0 have disease that's more than 50% stenosis, and less than 3%, about 2% or so, have some high-risk plaque characteristics on CTA. So even with this, we know that the risk of outcomes is very, very low in patients who have a calcium score of 0, but it still suggests that there is a residual number of patients who have residual disease that we're not picking up using a calcium score.
Is also age a factor here?
Yes. I think there is a slide here which I may be talking about, but yes, so the older you are, it depends, because this study was relatively small as well. We don't fully understand, but we think there is other components, diabetes, familial hypercholesterolemia, that tips the scale of 1-to-1 ratio from calcified to non-calcified, and it makes it a little bit more non-calcified. Studies have shown, this is a meta-analysis that looked at how does the plaque volume as measured by CTA compare with invasive gold standard. This is comparison with IVUS, and you can see that whether it's automated plaque volume or manual plaque volume, there is a really nice characterization and very nice correlation with the outcome, which is the IVUS, ground truth gold standard, invasive IVUS measurement of plaque. So we think that CTA is very, very good. And this is before the photon counting CT. I suspect that with the photon counting CT, which has higher resolution, we may be able to even get better estimates of plaque burden. There's multiple studies. This is probably one of the largest ones that showed that the burden of atherosclerosis, whether it's calcified or non-calcified, but overall on CTA is linked with MACE events, and also non-calcified plaque has a higher risk compared with the calcified plaque. So these patients, I apologize, you're not seeing I thought that you are. Give me a second. So these patients who are in the non-calcified atherosclerosis, they have higher risk compared with the calcified atherosclerosis and compared with no atherosclerosis on CT. And the burden of total atherosclerosis is also linked with MACE events as expected. When you start to adjust for pooled court equation, calcium score categories, the burden of atherosclerosis remains significantly associated with MACE, and also the presence of non-calcified plaque remains significant. Now, interestingly, when you start to incorporate pooled court equation, which includes risk factors, as you know, calcium scores, which and then a plaque burden, and the presence of non-calcified atherosclerosis, the presence of stenosis more than 50% loses the significance in relationship with MACE. So this at least gives us some indication to suggest that it's the plaque burden rather than the presence of stenosis that drives the risk, although this is yet to be debated because there's other studies that showed ischemia is an independent risk factor. Now, when we think about coronary atherosclerosis, as you know, there is a plaque, lipids build up in the intimal thickness, and then lipid build up, and then it starts having this kind of bulging, which is positive remodeling is what we call it. And then there is a necrotic core, and then there is microcalcifications. These are kind of the things that we see on IVUS or OCT. We see a necrotic core, we see ThinCap fibroatheromas, TICFA, spotty calcifications, and we see remodeling. But how does that relate to CTA? On CTA, we see similar factors. So the positive remodeling is seen, and sometimes we do comment on it in our lab when we see it. We do see low attenuation plaque. That means that there is lipid-rich kind of plaque. We do see this napkin ring sign, which looks like this. Basically, you see a very hypoattenuated core, and then there is kind of this thin layer of hyperintensity, and then this is the lumen here. And this is a napkin ring sign, suggests that there is necrotic core, and then the spotty calcifications are really an extension of microcalcifications that start to become nodules and so on and so forth. So these are kind of the classic 4 factors that we see on CTA that suggest a high plaque features. And studies have shown that the number of plaque features, adverse plaque features that we see on CTA is linked with incidence of myocardial infarction or stroke. Now, beyond just the atheroma phenotyping, it turns out that when you look at CTs, and this is an interesting study that was done in 2017 at University of Oxford, where they looked into the attenuation of fat on CT. The fat is traditionally negative, so we think about fat as minus 30 Hounsfield unit to minus 190 Hounsfield unit. So the more fat you have, the more dense the fat is, the more negative. So the less number, the smaller the number, the less negative. The more negative. But as you get these, the way I think about it, as you get these impurities, cytokines, inflammatory markers, some other things, even maybe perfusion and fluid and vascularity, you get more, you get closer to the positivity, you get closer to the minus 30. So it turns out that when you do this and you take biopsies of people, that this does correlate with inflammatory markers invasively. It does when you look at PET CTs and you look at subcutaneous fat, attenuation, it does correlate with FDG uptake. So it kind of characterizes inflammation. The more positive the Hounsfield unit, the more inflammation. But how does that correlate with cardiovascular disease? And it turns out that if you look at the pericoronary adipose tissue, the fat around the heart, the coronary artery, especially in the proximal segment of the coronary artery, this also applies. The higher the intensity, the closer it is to zero, the less negative, the more risk. And this, you can see here, the adjusted hazard ratio of there is a specific cutoff, minus 70 or so. Anything above minus 70 is significantly associated with higher MACE risk after adjusting for risk factors. And this is actually additive to the plaque characteristics. So when you have plaque analysis and you see the plaque characteristics and you add to them this FAI, which is fat attenuation index, which is really just the Hounsfield unit of the fat, then you see an added incremental value for MACE prediction. Now, we spoke about the plaque characteristics, but is this a modifiable thing, or is this just something that we're looking at and it is just observationally linked with outcomes? It turns out that it is actually modifiable. So this study of when you put patients on statin, what happens is that we know that there is an increase in the calcified plaque volume because the non-calcified plaque converts slightly into calcified and gets more stabilized, and then you get a less non-calcified plaque in general. So there's a conversion of non-calcified plaque into calcified plaque by statin, and that reflects stabilization. Vasipa, this is a trial of Vasipa that looked into kind of replicating the REDUCE-IT trial, which showed significant reduction in MACE events with Vasipa in patients who have hypertriglyceridemia, but this is a mechanistic study that is called EVAPORATE, where they looked at about 100 patients, looked at the progression of plaque by CTA by Vasipa versus placebo, and you can see that Vasipa can actually change not only the total plaque volume, but also the characteristics of the plaque. So it reduces the fibrous, the fibrofatty, and then the low attenuation plaque to a certain degree, but no difference in calcified plaque as can be expected.
Can we revisit that for a second?
Yes.
So there's some confusion here when we talk to patients because with statins, there's healing of the plaque, there's reduction in the subcomponents, but the calcium goes up.
Correct.
But then you have other data that people who increase the calcium score have higher risk.
Correct.
How would you reconcile that, particularly for patients, because they
Yeah.
get really scared when you
Right.
repeat this score, and it went from 75 to 150.
Right. So the question is about how do we reconcile the increase in calcium score versus the reduction in risk? And I would say the first thing I do, I just don't generally, if I put patients on statin, I generally don't repeat calcium scores.
don't either.
Yes. But if they happen to have it repeated at somewhere else, the way I explain it to them, and I explain it a priori, and when I put them on statin, I say, this is what's going to happen exactly. What it means is that this calcium is not going to change. It may increase a little bit. It's not going to increase a lot, but it's going to increase a little bit, and it can increase with your age. But what we're changing is what it means. The meaning of that calcium is what we're changing, not so much the calcium itself. I wouldn't worry too much about the calcium. The calcium is not causing a problem for you, but what it means with respect to heart attack risks and stroke risk is what we're changing. So that kind of conversation.
So the data that shows an increase in calcium score having higher risk is for untreated patients?
Correct. Yes. Yeah.
Yeah, that's
So
important.
yeah, and the increase is usually not like a huge increase on statin. We're seeing small increases depending on which study you look at. So it's not like doubling or tripling of the calcium score. Generally, it's a 10 to 15% increase. So I think that's mostly for untreated patients because this was done from MESA. The ones on calcification, and, I think there's also this residual component of what if the progression is happening because you're not treating them well, right? And that is hard to kind of differentiate between patients who have, well-treated lipids. I also wanted to kind of mostly for the fellows, but not all stenosis that we see on CT is actually atherosclerosis. This, if you look at this looks like atherosclerosis, but if you kind of dig deeper into this is a young woman who has what we call fibromuscular dysplasia and had a prior dissection in her femoral artery. And it turns out that this is actually a spontaneous coronary artery dissection. So whenever you see it's hard to kind of evaluate this on CT sometimes and differentiate it, but kind of keep an eye on patients who have calcium score of 0, young, especially women who have an event, and then you see some stenosis. One of the differentials should be SCAD, specifically in this patient population. Now, what do we do with this information? Now, we have this plaque. We have now AI to quantify the plaque, because one of the hardest parts in plaque analysis was how do we quantify it? We can tell you mild, moderate, severe visually, but is that accurate? And how do we quantify it? And I think now that we have AI systems that are FDA cleared to actually estimate automatically in a few seconds, estimate the amount of plaque, how do we move this into clinical practice? And I think this is one of the biggest dilemmas because we don't actually know. It turns out that most people, even young people, we do a CTA on them and do plaque analysis, they end up having some plaque by AI. So does everybody need to go on statin? Does everybody want to go on aspirin? How do we, where do we stop? Where do we stop the train? And I think one of the areas that people are studying right now is really population-based percentiles, similar to how we did it with the calcium scores. But I think it's hard because we don't actually have good population-based studies. Most CTAs are done in the world are people who are referred because of a reason, right? They have chest pain or pre-op or whatever it is. So I think this is going to be a big problem for this AI plaque analysis because everybody has plaque, and then when do we draw the board? And I think, in my opinion, I think the solution is really by focusing on the outcomes. So if we know that this many milliliters or cc's of plaque can correlate with this much risk in the future, then we can understand it using what's equivalent calcium score, what's equivalent diabetes risk, and so on and so forth. But people are, as you can see, there are people who are advocating for serial CCTAs in patients who have plaque, and then that causes a little bit of a problem. I think we're studying it right now with this trial called Transform, where one of the sites at Methodist that we're testing this strategy in a IRB approved study where we take patients who are primary prevention, diabetes or prediabetes or metabolic syndrome, and we're randomizing them to CTA versus usual care, and then we follow them up for incidence of outcomes and see whether CTA changed the practice. To my knowledge, there's no trial that compared CTA with calcium score because there's very, very marginal difference, in my opinion, in terms of discrimination. So I'll spend a couple of slides because this is a multi-modality. I wanted just to bring up other modalities, not talk all about CT. But echocardiogram, we don't think of it as a prevention strategy, but actually it does produce a lot of information that can predict risk of major adverse cardiovascular events. This is from a population study where we looked at the texture and the motion of the left ventricle from apical four-chamber view, and then you can actually classify risk of major adverse cardiovascular events up to 10 years down the road. So in theory, in the future, this could be an approach where we can take and opportunistically identify risk of MACE without having to do additional scanning. This is another interesting study that people have looked into using AI on parasternal long axis to predict calcium scores. And it turns out that it actually does a fairly good job. You have an AUROC of 0.85 to more than 400 versus less than 400. There's another figure in the same paper that looks like it can predict calcium score more than 0 versus 0. So it can quantify calcium score. And what is it looking at? We don't actually fully know, but it looks like it's looking at the aortic root. So it's looking at the right places. Aortic root, it looks like the septum. So maybe it's truly picking up some reverberations or some reflections of the signal from the coronary arteries, although in some, this left lower corner figure, it looks like it's looking at the anterior mitral valve leaflet, and I think it might be just focusing on valvular calcifications as a sign, because it does correlate with coronary calcification sometimes. Another word on CMR. CMR also, this is a highly referred population, advanced test, but nevertheless, sometimes it can be, we're referring a patient for PVCs and things like that, and we want to use this. So it turns out that ischemia and LGE, late gadolinium enhancement, are both independently associated with outcomes. So this is patients who have no ischemia, no LGE, patients who have ischemia but no LGE, LGE but no ischemia. When they add it up together, they have a very high risk of MACE events. So also think about kind of looking at other modalities to understand your patient's risk. And this is just another interesting AI study that was recently published that looked at predicting calcium score from chest x-ray. And again, it's sometimes it does focus on the heart, but sometimes it focuses on the aorta and kind of picks up the calcifications in the aorta because it does correlate with coronary calcification. But it does a fairly good job, actually, at identification of calcification. So this might be a new frontier in the future that can identify patients from pre-existing data that we have to understand their risk in the future of plaque. What about imaging plus? So everything that I talked to you about right now is just one imaging modality. Calcium score alone, CTA alone, CMR alone, and echo alone. But what about we start adding things together and see what happens? So on the left side, you see a study that combined calcium score with high sensitivity troponin in a population base. This is not patients who are coming with MI or chest pain. These are patients who are asymptomatic from MESA study. And it looks like when you combine calcium score and high sensitivity troponin as categorized as high or detectable, non-detectable, you can see that when they're both elevated, you have very high risk. When they're both low, you get very low risk, and everything in between is graded risk. This is a study that we did where we said, okay, instead of getting an additional biomarker and all that stuff, you have a patient address, you have their zip code. Let's just convert that zip code into a social determinant of health, a measure called Social Vulnerability Index, available for every neighborhood in the United States. And you can see the same story. This is about 50,000 patients. As calcium score goes up, you get a graded risk, but then this risk can be actually reclassified by this Social Vulnerability Index. So just by looking at someone's zip code, and you can just convert that into a simple number that can give you an added value for free without having to get another biomarker. We also have thought about something that's very simplistic. Almost every patient who has a calcium score, they also have an EKG. So what if we combine the EKG? Can we come up with an EKG risk score, ECG risk score, and add it to the calcium score and see whether that can enhance, and whether we can enhance it even further by adding some clinical risk factors? And it turns out, yes, this is in yellow is ECG plus CAC, and in black is ECG is CAC alone, and we see approximately 8.8% increase in the discrimination. And then we came up with this risk score that takes the ECG risk, but you can plug in a CAC score, age, female, and you get a kind of a linear nomogram to identify the risk. So what is the future? The future, I think, is there is an investment, a lot of investment into these radio tracers and or MRI technologies to really phenotype the plaque, especially for larger than coronaries. So carotids, people are working a lot on the carotid, looking at T1 mapping and so on and so forth from MRI to identify high vulnerability plaque. There's also, like we mentioned, this sodium fluoride. People are working on it to identify earlier stages of inflammation, but also microcalcification. And I think people are thinking about plaque characterization in anatomy, but also plaque activity. I think there's also some investment into looking into beyond Agatston score and looking broadly at the population as part of opportunistic. So looking at valve, and even on the same CT, looking at heart, epicardial fat, looking at the plaque characteristics. I think we're not milking the calcium score CT enough. There's a lot more information that we can acquire that can help us identify the right patient for the right treatment. There's also some radiomic approaches, body composition, fat, muscle, retinal images, and ECGs that have not been incorporated. And I think the future is really multimodal. You can combine all these with clinical data, with the neighborhood variables, with wearables, hopefully in the future, to come up with a refined risk prediction, not only to give you what your risk in this future, but also what is driving that risk. Is it fat? Is it pericoronary adipose tissue? And then use that to kind of use the right treatment precision in a precision prevention framework. So my take-home messages is we talked about personalized prevention, which really may be needed to identify individual unique profile. Multimodality can enhance this understanding, although we're not there yet, but I think we have the tools to actually start to quantify some of these things. The advanced analysis of multimodal images can really help us understand near and long-term outcomes, near future and long-term outcomes. And as we mentioned, the future directions are there's investments into deeper phenotyping with advanced testing, whether it's PET scans and or MRI to identify the right plaque, but also there's investments in population, opportunistic kind of free of charge additional value for imaging. And what we missed throughout this presentation, which is the field is missing, yes, we can identify risk, we can comprehensively link those, but we haven't linked any phenotype, individual phenotype, with a specific treatment. So even though we have treatments for inflammation, we haven't identified a phenotype or a biomarker on imaging that can identify patients who can benefit from inflammation therapies. And thank you very much. Any questions? Okay. Thank you. No questions.